Hi. Such a we have been talking healthcare. I think I just landed back from WSIS, and we have been talking about AI for good, and healthcare was such a big discussion in that entire ecosystem. Got me thinking, today we are here and we have an esteemed panel of health practitioners and hospitals asking two very interesting questions. One is, what's the cost of care really? And who absorbs the cost of care? I mean, of course, it is seen there on the panel, but I think these are two Oh, of course. Thank you. These are two distinct questions, and I think needs to be unpacked in the same way as we go about it. So, healthcare has never been more advanced. We have now AI enabled diagnostics, we have precision medicine, robotic surgery, so much that I actually have to read through the full list now. But the point is, it has advanced so that now much more is solvable than it ever was. And yet, millions of patients today still face the gap of health delivery and health access, especially because we still face the problem of affordability. India, in that case, has made significant strides in strengthening the health financing systems. We have Ayushman Bharat and Ayushman Bharat Digital Mission. These two have been very successful. According to the National Health Accounts estimates, government health expenditure now accounts for almost 43% of India's total health expenditure, and households are covering the rest of it. Better than before? Yes. Enough? Definitely not, right? Today we have now, contributory and compulsory financing schemes that are covering at least double what it happened in the last decade. So it used to be about 6.7%, now it's more than 12%. And that is reflecting a progress in the financial protection system. But yet, the conversation is far from over, right? Just this week, the Parliamentary Standing Committee on Health recommended that Ayushman Bharat coverage is going to increase from 5 to 10 lakh rupees, recognizing that the cost of several life saving therapies have increased and the coverage limits should match. But then, what is the discussion today? So, today we also have hospitals who are managing rising operational costs, clinicians are treating increasing disease burdens and chronic and probably solvable disease issues. We have insurance who are always crying about making a loss. I have to figure out someday why. And the evolving reimbursement models and investor expectations are somewhere off balance. So, today as we sit here, where we have an esteemed panel of hospitals, clinical practitioners, healthcare investment professionals, and health system strategists, let us have a unique perspective on where cost originates. So, for with that long prelude, I would love to throw the first question to all of you. From your perspective, what's the single biggest driver behind rising healthcare costs today? Is it technology adoption? Is it workforce shortages? Growing burden of chronic care, inflation in medical inputs, financing models? What is it? Like, or whatever answer comes to your mind.
Sure. Thank you. Thank you, Financial Expression, FE team, to have me here. So when it comes to single driver, I believe there will be no single driver leading to the cost inflation. It's a mix of nuances across the Indian healthcare system. It is one of the biggest thing is the increasing cost. Yes, but cost is not attributable only to the inflation. Cost is intensity cost, right? When the patients are coming now, it is delayed diagnosis. So comorbid conditions. India is moving from a Indian healthcare is moving from a acute episodic care to more chronic care. So it is more of a delayed diagnosis, comorbidities, fragmented care. So patients go from hospital to hospital for their healthcare needs across the entire ecosystem. They are required to get that same test repeated or maybe multitudes of treatment, right? So hopping patients. So to put on a thing that the healthcare is expensive in silo, that's not the real statement. It is a fragmented care, a delayed diagnostics, leading to the entire thing. So not a one single contributor to this thing. So that's my stance on that.
So, before I start, I would like to take your permission to add few comments to the previous session, if I may. So I must say that I was listening to Dr. Basu in the previous session, and ma'am, when you spoke about the use of tabs by ABA workers, it's a perfect use case for technology. In all the conferences we go today, the buzzword is AI. But the problem is in healthcare, we are so deprived of technology. Pardon me for making that statement. We are so deprived of basic technology that AI is far, far ahead. We need to have basic technology, and a wonderful use case pointed out by ma'am. Tabs used by ABA workers in remote places to upload the information. So we need this level of basic technology first, and then we can talk about AI and other things. So sorry, I took your time for commenting on the previous session. Now, regarding cost of healthcare, I think at PB Healthcare, we have been trying to figure out what exactly are the 2 or 3 top reasons which lead to high cost of healthcare. And we figured out something very simple. First is it is not some high-end technology, it is not some rare disease or complex surgery which is leading to the high cost of healthcare. We found out a very simple reason. It is the delay in seeking care, as sir was also saying. So access to the healthcare has to become very easy. That will lead to a lowering of the cost in healthcare. You ask any doctor, they will tell you common scenarios, very common scenarios. A patient with high blood pressure undetected lands in the hospital with stroke or heart attack. Somebody with untreated diabetes landing in the hospital with complications like renal failure and then requiring dialysis, transplants, the higher end of the costly spectrum of therapy. Somebody with simple infection progressing to the stage of sepsis, multi-organ failure requiring all sort of organ supports. So problem is we have built systems that are excellent at handling emergencies, but not at preventing them. Healthcare should not begin in ICUs, it should not begin in ERs. It is supposed to begin the moment a patient notices a symptom. And at that point of time, he or she should be able to seek timely medical attention. So, how can we make access to healthcare easy, affordable, will decide the cost of healthcare in future? And the second reason, what we found out was slightly more controversial. It is about the payment model in the current healthcare industry. So, most hospitals these days operate on fee for service or MG plus variable model. And this model incentivizes maximizing per patient revenue. So this is one of the second most important reason which we need to address, which I think should be able to reduce the cost of healthcare in times to come.
Dr. Mathur, thank you so much. I just want to add one
Yeah,
thing.
sure, please.
Healthcare system should not begin when patients see the symptoms. It should actually be in a place where patients do not get symptoms. That is what healthcare is.
Agreed.
Just,
Hmm.
but we can talk about that
Sure.
in a bit. Yes.
I think as Vishal said, so there can't be pinpointing of one reason, but I would say the leading reason uh, could be is about the shift of the disease profile. I think the more and more the complex procedure, complex diseases. So when you have to create the ecosystem to treat those chronic problem and high diseases, you have to have a very good infrastructure. You have to spend on the infrastructure. You have to have a very high skilled doctors, right? Those who can do that, and to perform that procedures, you have to have a very advanced and very high in technology, right? That whether it's robotic or any various other things. So and then rest others are manpower cost. So the leading factor is about the how the burden of the chronic diseases, the management of the burden of chronic diseases. I think that is a leading cause. Rest other comes within the managing those. I mean the ecosystem of managing those chronic diseases.
Thank you so much.
Good afternoon. Maybe after my statement, Financial Express will decide that not to call me again for a panel. I'll say it's a failure of prevention. Where's the primary healthcare in our country? How many of us have had our last health check? Raise your hands up. 10%? All educated people attending the Financial Express Health Summit. Come on, my answer is as simple as that. It contributes to you reach your hospital only straight to the ICU, and it's bound to be expensive. So to travel from point A to point B, when you could have done it on a cycle, you have decided to take a train all the way to some other Timbuktu and you have to fly back from there. It's as simple as that. So there's a gross failure of, and as a clinician, I'm saying, the gross failure of primary healthcare, secondary accessibility to secondary healthcare is, limited, and we are building bigger and bigger tertiary care centers. Of course, it's going to become expensive.
So actually, I do agree with Dr. Anand. And from where I see it is, it's not, I mean, the cost of care is going up because our model is, the healthcare system is designed in such a way that we are rewarding, or rather we work on kind of treating the disease a little late rather than preventing it a little early. So we actually reward intervention over prevention. I think from, if you look at it from my eyes, I'm also a doctor, practicing doctor, the chronic diseases are increasing. They're coming in early and they stay longer. So the way I see it is, someone is getting diagnosed with metabolic conditions like diabetes, fatty livers in early 30s rather than 50s, 60s, 70s. And we know that just one consult is not okay enough for this chronic diseases. That the cost runs into decades. And that's the whole point. So everyone sitting here, I just want you to sit with this, that this burden doesn't start anywhere close to a hospital. It starts at our houses, it starts in our kitchens, it starts on our offices, on our holidays, our festivals, because it all depends on how we eat, how we sleep, whether we exercise, whether we smoke, we drink alcohol, how we manage our stress all over these years, which eventually leads us to the diagnosis. By the time we reach the system, we are already paying for the most expensive version of the problem. So definitely the inflation, medical inflation is going to go up. But the problem is our system only gets activated after the patient is already sick.
Ajay ji, I would tweak the question a little bit for you because you have seen so many health systems from a 360-degree thing. Um, I mean, not about what's the burden of care, but mostly what's the cost? What's really the cost of health delivery? Where do you see the larger drivers lying? I have had this discussion with Pinak too long. So please. Yeah.
Sure. No, thanks. No, we heard a lot of interesting perspectives. I think most of my fellow panelists are from the provider space. And we are trying to look at the problem from a different angle and trying to be part of the solution by backing healthcare innovative models across the healthcare value chain. And yes, medical inflation is twice the normal inflation. Yes, it's hurting across provider, payer, pharma, and all. Everyone is contributing to it. Your insurance premiums are going up. Your uh, medicine costs, even though it's in certain cases controlled and in certain cases subsidized, but you were still paying quite a bit. And of course, on the provider side, with hospitals and diagnostic centers, we know how it's happening. But as some of the fellow panelists already mentioned, if you essentially attack the problem early, if you essentially do early screening, early diagnosis, preventive wellness, and because India was largely out of pocket, we are still more than 50% out of pocket. There was no payer pocket for it, and health awareness has started to spread nicely. I think a lot of steps have been taken in the right direction, and we may have another decade to go before we at least start reaching closer to WHO standards. We are short by 1 million doctors, 2 million nurses, 3 million beds. So for you to essentially, and I see you've been a UN advisor yourself. So for us to bridge all of this in a linear fashion will require significantly long time and significantly higher capex. So that's why we focus on innovative solutions which essentially can break this and can solve for affordability, accessibility, and quality of care. So we've backed a diagnostics company. We have backed a chronic care disease management company, which some of my fellow panelists spoke about. We backed an AI diagnosis company. We have backed a company in AI-based mental health, a very few from India, which have not, and these are frugal innovations developed in India, and they're not just solving for India, but for other LMICs and emerging markets as well. So
For the global south, largely.
yes, global south. So so that's what that's what we do. So we are also trying to be part of the solution here. Of course, we know some of the challenges, but together we can solve it.
No, thank you so much, Ajay. And would love to talk more on that in a second. Before that, I would love to go down the rabbit hole on, because we have a lot of providers here. We have a lot of, sorry, am I audible now? Sorry. So, because we do have a lot of hospital administrators here, especially to you, Dr. Vishal, as well as Amit sir, would love to understand, where do hospitals face the greatest financial pressure today? Like, right, yes, we are in a financial express seminar, but we also understand that finance, along with healthcare delivery, is the backbone of how we operate, how we structure. Um, so, how do you balance the investments in innovation and quality with the need to keep healthcare accessible? That's one. And also the problem of accuracy of health delivery, right? Which is a problem that sometimes I find so confounding that I would rather not think about it, right? We had this whole project going on with Anthropic about how to really make, okay, and this is going to sound really quote unquote because it is, AI doctors. But the whole challenge was that we don't sometimes the saying. So I remember when we were at Wharton and we used to study financing from health perspective. The whole idea was that, and the saying goes that we don't stay alive as humanity because healthcare has progressed, but sometimes in spite of it. So, what is the answer then? What are the cost burdens and how do you balance these two?
Sure. So I'll go. So the biggest challenge for us as a provider, the widening gap between providing quality healthcare and what we can actually receive from a patient in returns of the care. The gap is slowly and steadily, I'll say, narrowing, right? So the gap is narrowing on a day-to-day basis. When it comes to quality, affordable, quality care, today everyone wants to get the best in class healthcare. They want treatment. Everyone would expect a treatment done by a robot or advanced diagnostic imaging, or maybe a targeted therapies in terms of when we talk about oncology. But everything comes at a cost. When it comes to, and we've already spoken about the healthcare inflation cost, right? It is almost double. So one of the stats says the healthcare inflation cost was 15% for last 2-3 years, against a standard inflation of 7-8% or 6% approx, right? So now this automatically has to be passed on to the patient. If the healthcare inflation is going out, high end technologies are coming in, skilled labors are required, to skilled workforce is required to actually operate on those technologies. And when it comes to a robot, a Da Vinci robot today in India would cost approx 14 crores. Just imagine a 14 crore robot for a 50,000 lab colleague. It cannot happen. One case of a Da Vinci robot, the consumables, forget the fixed cost, 25-30,000 going into a robotic surgery as a OPEX for a hospital, versus a expectation of a government scheme, a CGHS beneficiary or a GIPSA trying to close the complete lab coal in 50,000. So this gap is day by day, it is narrowing, and that is one of the biggest threat what we see in healthcare. And of course is the cash flows, right? Now to answer your second part of the question, where should we invest, right? So we typically see, if one of the followings are met. If I would like to invest in a technology, if it increases my patient outcome, if it increases my patient satisfaction, if it increases my overall productivity, or maybe yeah, it increases the overall productivity or throughput. So if any of the following are met, will more than be, I don't want to invest in a technology because I can afford to do that. But in case one of the four metrics are met, we will be more than happy to invest into the technology, and it should also have measurable end outcomes. Yeah, so that's how I would answer.
Yeah, so the first part I think Vishal has covered really well. That's yes, there is a gap. So for as a provider, I'll tell you, as a hospital administrator, is there's a tremendous pressure on us. That's the expectation. Expectation is about provide the best healthcare, best quality healthcare. To create that best health best quality healthcare, as I said previously, that ecosystem which I talked about, the technology, manpower, the infrastructures, that's there. But the important is the price point on which the highest standard of the healthcare, who is buying it? So the payers or the patients, are they prepared, are they ready, or do they pay? So that's the one very stress situation, right? Patient wants the best, but I think probably a region that they're not going to pay. As I give an example, let's say one laparoscopic surgery will cost me, let's say, 100 rupees. But if you do that, if you have a robotic surgery, if you do the same procedure, I mean, you'll have to pay 100 plus 40, 50 rupees more, right? So that's point number one. There is a gap. Second is about, yes, that medical inflation is it's a probably, I would say, the highest in India, I believe. As compared to the consumer inflation, yes, I think it's a 2.5, 3 times higher. Another pressure what we face from the payer side, that's the tremendous pressure from the payer side to reduce the cost, right? So they're gonna be arm twist you, depends on how big you are, right? How big player you are. So if you're not that big, then probably you will be face that music more. So that's a third point. Fourth, I would say, the if you provide those procedures and the surgeries and the infrastructure and everything is there, then you don't get the payment. So payment, particularly from the, because certain section you do as in a government, and others he touched upon CHC or something, so they don't pay you that much. So these 3-4 angles are very stressful for us to keep a balance. Uh,
No, and
and technology, what Vishal talked about, yes, I would love to spend 1 rupee of mine where this technology bring that efficiency, and then give me the better outcome, clinical outcome. It brings it gives me my increasing my network, or probably remote clinical management system. I mean, these are the things where I can reach out by having the one place, and how my geographical area, how I can reach out. I think these are the area which I would prefer, where I would invest more on technology.
so I think there is a balance that needs to be stricken between frugal, cost-effective care delivery, between best-in-class innovative solutions in areas that is necessary. Yeah, of course.
I'm sorry to interrupt, Sabine. Uh, the healthcare delivery system in India is not thinking as one, or one organism. We are multiple organisms. Why I'm saying that, I'll tell you a small case story. This was in 2012, Da Vinci S. The first version was, because you spoke about the intuitive system, sir. So I was at that time in Edinburgh, Scotland, and I was a part of a team. We were trying to decide the disease burden and how many Da Vinci systems does Scotland require. Okay, and at that time, the only indication for a intuitive robo was a malignant prostate or a nephron sparing nephrectomy. Only two, nothing else. You don't go into the pelvis, you don't go into the hepatobiliary, nothing else. No extended indications at all. So initially, it was proposed to buy 6, but then we found that if we funnel it and put one on the east coast and put one on the west coast, 2 machines were adequate. In fact, some people from the intuitive were very unhappy with me, but I had to give the facts. So now, how many intuitive systems are there in the city of Delhi? In my tier 2 or 2.5 city, there are 1, 2, 3, 4. So will it not increase your cost? So that's why I said, if this is a national level forum, that is why I'm opening it. And if we think at a national level to deliver healthcare, I think these are certain very difficult questions we all need to answer.
No, thank you, Dr. Anand. I think well said. As I and you made my point was I was trying to make as well is the same thing that for a hospital the PNL is important. We have to understand that we are no longer we are businesses too, right? And investments goes into operational efficiency as well as into best in class care that delivers right ROIs. And that balance is sometimes very difficult to achieve. But as we ponder more on that side, I would love to actually ask Dr. Chadda. Uh, Today, preventive care and lifestyle medicine is reducing long term costs because it's a long term preventive care, it's long term personalized medicine. And both patients and the healthcare system probably can benefit by reducing that burden. But we are investing disproportionately in treating this area of medicine as known. So, first is how, and second is the personalized aspect of it also reduces the level of scalability of the same. So, how do you solve these two?
So, lifestyle medicine or personalized medicine, they're two different things. But if I speak more from a, it's there's an overlap between the two. But lifestyle medicine has picked up pace over the last few years, and it's definitely good
So,
pace.
we can bundle that as functional medicine.
Functional medicine. Again, yeah. So we can put all the three words together, but they are focused on a lot of preventive care, basically. So the good thing is it's picked up pace, but it's still a little slow in the sense that it is still taken as a third wheel. It's something that goes maybe it's very soft, it's very adjacent to the conventional treatment, which I think is one of the mistakes. It needs to become the front end of the healthcare system. Now, why is this so important? I feel is because now imagine you're constructing a building. If your foundation is not strong enough, your building is going to collapse. It's a matter of when and not a matter of if. Now, lifestyle is what you do or what a patient does every day, right? So, your lifestyle is actually your foundation of health. So if we can correct a patient's lifestyle by understanding root causes, what they eat, why they eat, whether they exercise, whether they smoke, and we correct it over from a root cause perspective, then we can actually strengthen their foundation, which could help them prevent or postpone these chronic health conditions. Also, even if someone already has things like diabetes, you could actually prevent the complications of diabetes, which actually is a major cost for procedures and a lot of burden of lifetime medications. What I feel is that prevention goes underfunded because it's very difficult to invoice a diabetes or invoice a heart attack that didn't happen. It basically gets missed. It's completely invisible on your accounts, and it kind of goes underweight because of the model. So I think that we really need to start focusing predominantly on the prevention part also. Otherwise, we will end up paying for the problems which are at the most expensive level. So I feel that at the end of the day, lifestyle medicine from a preventive perspective, we need to incentivize rather the preventive care. And I'm sitting with a panel of people working in hospitals, seniors working in hospitals. So even to include things like lifestyle medicine, preventive care into the hospital as a system, not that the tests are done and the patient doesn't know what to do with the reports at the end of the day. So if this can become a specialized field, I think that will help a lot of hospitals, that will help a lot of the healthcare system and the individual patients, because right now also everybody sitting here knows what they need to do to take care of themselves, but they're still not able to do it. And that's where the lifestyle expert comes into play, because we will help you design your 24 hours. We all get 24 hours to do the best that we can.
No, understood. But just a quick follow up before we move on. Right, we all know the stats. 60% deaths are preventable, 55% health expenditures and admissions are preventable because of preventable causes. That being said, from a P&L perspective, personalized medicine is not scalable today. We do not,
Stable.
yeah, it's not scalable today. So, what is your thoughts on how technology can play a part in solving that problem?
So technology for personalized care.
How technology can play a part in making personalized preventive care scalable, because
Stable.
right now you have to depend on the judgment of the doctor, the intuition of the doctor, and you need enough trained super specialists in the field.
Correct.
We don't have those. So
So technology, now again, if you talk about living correctly or living the right way, personalized care, again, if you're saying more from a preventive perspective than treatment perspective, I think things like even social media is going to kind of take a little bit of role. Things like probably even online consults, group consults, all these things probably also get involved. If that answers the question.
no, but I think Ajay ji wants to say something.
No, so there's one on the curative side and there's one on the preventive side, right? If you're talking about personalized on the preventive side, when your health check happens, that's personalized, right? It's coming for you individually. You can have a genomics report as well on top, which will be your personalized, and nutrition and lifestyle will also be personalized. So if you combine all of this, then you will have a personalized assessment at the preventive end. And then, of course, there is so much happening on the curative and the treatment side with the precision medicine, etc., whether it's chemotherapy, etc. Everywhere, it's much more personalized. But on the preventive side, if you'll have to combine all of this. So you'll have to combine nutrition, lifestyle, preventive report, genomics, everything, and then you have a good assessment.
Agreed, and we'll have to make sure that the solutions, the therapy side of it, even within the preventive space, is more block structured and scalable so that we can reduce or expand the scope of the lifestyle medicine doctors or functional medicine doctors who are far and few in between to a larger audience, I believe. But on that note, Dr. Mathur, I would love to know your thoughts on a couple of things. Um, considering that you are with PB, we do assume that insurance is one area that you understand a little better than most of us. Um, as mentioned earlier, we do know that today insurance is becoming a key paying partner. And the government sponsored insurance now finances what, about 13% of India's cost? So, on that note, today's reimbursement and insurance models, do you think are they keeping pace? Are they keeping pace with the hospital's realities? And if not, what are the changes necessary? I mean, we have been speaking about solutions at reimbursement, speed, of course, those are there. But are the actual models really keeping pace with the costing?
So, in fact, I was listening to Dr. Amit and the way he was telling about the pain points that the providers have face. So the angst is everywhere. Uh, and so the current healthcare insurance landscape is a very fragmented one, no denying the fact. It's there. There are three players: patient at the center, provider or the hospitals, and payers or the insurance companies. As of now, unfortunately, all three are in a state of in a triangle of mutual suspicion. Unfortunately, there is complete breakdown of trust. And the irony is that each party feels the other two are to blame. So if you listen to the hospital side, they have to face reimbursement bottlenecks. We all know that, arbitrary claims denials. There are some justified causes for medical inflation. Hospitals have to adopt new technology. The healthcare workforce cost is increasing day by day. The care for increasingly complex patients, all those things are not getting reflected in the tariff renewal. If you listen to the insurer side, they have their own set of complaints. They say there's no standardization of healthcare cost across hospitals and billing is very opaque. They also feel that at times hospitals resort to inflate bill and resort to various strategies to inflate the bill. And on top of that, there is fraud happening, which is also eating up in the profit margins of the payer companies. So both are having genuine problems. The biggest loser is the patient in the middle of all this. Unfortunately, the system is designed to help them, but they are the one ending up on the loser's side. They have to face unnecessary out of pocket healthcare expenses, opaque billing, and so many other challenges. So there is complete mess as of now. And I think we have to come up with solutions as a society, as an industry. We at PB Healthcare are trying to do that exactly. One of the possible solutions is basically we have to find a sustainable solution which does not transfer the financial risk from one to another. It protects the interest of all three. So it's a difficult problem to solve, but we will have to come up with some solutions to this.
No, personally, I think, well,
So, Doc, very well said, and I'll say it's like a husband, wife, and mother-in-law, right? They have to live with each other in the same ecosystem, but can't live together. Yeah, so that's how it is. But to answer that, right now we are working with CIA and IRDA, and we are trying to create a NHCX, National Health Claims Exchange portal, right? So on which there will be integrations between the hospital and the insurer and the TPAs, and there will be a real-time flow of data. It will be linked to my HI sitting out there. So what you talk about over inflation and everything, that's not the unanimous case across, but yes, having said that, there are nasty players who are doing that. So there is a unanimous flow of information where clinical information from my system will go and sit out in the TPA desk, and from there reverse info will flow and come back in my HIS, and all the claim exchange and everything will happen seamlessly through that portal. So that's something work is ongoing, and the pilot is about to start. So that's the system we're
So
working on. Yeah.
all the genuine players are eagerly looking forward to NCAs to come into the market.
Yeah, in fact, some of the pain points what the hospital has, like today, again, it is not about pointing finger at a hospital or a insurer. Like once the information is sent, typical time like a discharge announced at a doctor's round at 10. The billing closures, the discharge summaries would be around 12, right? That is the same time when hundreds of hospitals, thousands of hospitals across the country would load the insurer system with a massive discharge request, and that 3 4 5 hours of time lag, that is not to be blamed, because we cannot have a one-to-one mapping on the case basis, right? Though the volumes are there. So once this exchange comes in, patient is benefited, insurer is benefited, and at the end the hospital is also benefited, because and we also have always a fight on this, right? Who pays for the extra half day of the rent which the hospital is, the patient is overstaying? So many such problems are getting solved, and hopefully should get solved soon.
No, health claims exchange, I think, is an interesting idea, and once it kicks in, it should be very beneficial. But just principally speaking, I've always been very gung-ho on insurance as a product, right? I mean, se what it started 800 years ago with shipping industry. We are still stuck there with Hormuz right now, and I mean, just the fascination of distributed risk and how we are able to now control that and also provide, and it's not just for the health industry, across. Insurance has been pivotal in growing businesses and otherwise. So, insurance has always been a financial backbone, a financial entity which many have misunderstood, most have never tried, but has promoted businesses across. And we need to, in a way, start looking at it from that perspective, not just as adversarial entities in the financial space, but as collaborators which help you grow through access to fundamental capital across the operational value chain. I think that is something that logistics as an industry started with, but high time we also start looking at it from that perspective, in my very, very honest
So
opinion.
totally agree with you on that. Uh, Internationally, there are models, similar models, Kaiser Permanente in US,
The
Discovery Health in
VBIS
South
model, like the
Africa.
value-based insurance model, yes.
Yeah, yeah.
Yes.
So it has to stay. There is no way that insurance can survive without healthcare, and healthcare can survive without insurance, as you were rightly saying. So we have to go hand in hand. We have to try to find out the solutions. But just like Kaiser Permanente and Discovery Health, we cannot replicate exact same model here. We will need to devise our own models with little bit modifications and some evolutions. But the evidence is there, the proof is there, the tools are there. The need is to put basically unambiguously patient first mindset. And we should, I think, in next couple of years arrive at a conclusion with so much of good work happening with the NCX coming up, the the healthcare insurance industry is stepping up. So I think solution is on the horizon. We should see that in 6 months to 1 year. And PB Health is exactly right, trying to
Yeah,
deliver that.
certainly. I think we had a very eager audience question. Is it okay if we take just one before we move on to the next question, if you guys are okay with it? You can. Oh, thank you.
My name is Piyush. Thank you, FE, for organizing this. So last year, a bill was passed. There are three acts which are now going to be repealed: the Insurance Act, the Life Corporation Insurance Act, and the IRDAI Act. So currently, it is now being repealed with a new act, the Sabka Bima Sabki Suraksha Act, and the rules are being formed right now, and it is open for public comments today. as I talk today. So would request all the payers and providers to be part of it. And this is one of the ways where we all understand there's a trust deficit between the patients and the providers, and so we understand that, but this is the right moment for everybody to maybe contribute to those rules and regulations. Thank you.
Sure.
Thank you
Can you
so
share the link for that?
Yeah, I'll share my number.
Thank you so much. While we move on to provider side and understanding a little more on that, Dr. Anand, can you please let us know, as someone leading a larger hospital cluster, do you see greater potential in technology and network care models as we have been discussing? I'm sure you have an opinion on the same, right? And what do you think about clinical standardization versus core personalized care? Also, from a PPP partnership model, do you see that those models drive sustainable and cost effective health delivery? What are your thoughts?
Let me put it into perspective. So, the first thing that you brought into the conversation is technology. Technology is definitely a necessity, it's not a luxury. But the same technology need not be in each of your units. See, what's going on in today's healthcare is in this country of 140 billion, with the tiring of cities, tier 1 and 2 and 3, that everybody's trying to replicate a Max or a Medanta or an Artemis or a Fortis FMRI or a Manipal Banergata Road or maybe a Baby Memorial Calicut. So that kind of replication, that kind of reduplication is not required. So what you need to do is build a hub and spoke model which works on strong clinical governance. So in this entire conversation, the standardization word came once. So we provide medicine, and medicine tries to give work on based on evidence, standard operating protocols which are there all across the world. So when we need to have models wherein you have a hub and spoke and you don't replicate technology. This is where your clinical governance, quality accreditation, systems like QCI, NABH, they come into picture. And see, from an industry perspective or insurance perspective, NABH is something like which is mandatory for me to take an insurance tie-up today. It's almost mandatory. So who is driving the quality? That's the insurance, the payer who's driving the quality. From a perspective of private, public and private partnership, I think that should be the future of our country. Just today afternoon, I had made a very bold statement when somebody was taking a video bite of it. If I'm not on record, I'll say that. Or even if I am, I'll still continue to do so. Having worked and been trained in the NHS and even in the Indian system, I would say that if India had stayed a British colony for 2 more years, we would have had a state-funded, free at the point of care healthcare system. Would you agree, Sabhi?
No. And I
Because
have worked in 120 healthcare systems now.
because
So I
because
would
if you
say no.
look at South Africa, South Africa still continues. It's not that they're problem free. It's they have their own problems, but the problems are a little different.
So I think what you said is right, but please, Doctor.
So I agree with the first statement Dr. Pai made, not the second one. The first, definitely, the need of the hour is standardization of high quality clinical protocols. And there comes the role of technology. We should have digital tools to enable those to develop. Obviously, development is not the easy part. The deployment is the tough part. So deployment of those standardized high quality clinical protocols, and they should be embedded in every clinical sort of prescribing workflows. So this will solve the problem to a lot of extent. And as you're rightly saying, we don't need bigger hospitals. What we need is hub and smoke model, fewer barriers, and more of primary care, more of secondary care. We definitely need quaternary care. We need those big 1,000-bedded hospitals with all the latest equipments. But we, at the same time, also need
We need
secondary
those
care,
referral
primary care.
models. We need those referral models. We need
Exactly.
primary, only the only needful transference of referral is
Yes.
necessary.
Yes. So it has to be a full spectrum, end-to-end care, not just the tertiary care or the quaternary care.
No, I agree. And I mean, just like to throw it in a little bit of Hindi, like खांसी के लिए अगर I go to an Artemis or to a PB में maybe I might be able to, but to a Yatharth, I think that's waste of the doctor's time and technology as well, right? So I think from that perspective, um, I'll add one more point to what you just said, right? As we look sideways and see other healthcare systems and how they have succeeded, proceeded, or failed, and learn from those, we should also look backwards and laterally so, right? Standardization was what made industrial revolution possible. Standardization in every field. That is why we were able to scale and scale fast across every country. Now we understand that there are fallacies in standardization because none of us are the same. I mean, healthcare for one really needs personalization. So there has to be a balance between now breaking out. So the whole movement around investment in female health is coming up now and it's blowing up, and that's fascinating to see because none of the clinical data was based on on female subjects. None of healthcare revolution happened on female data sets, and now suddenly we are waking up after so many years of development realizing that this is a problem, that more than majority 51% of the world's population is actually underserved. So I think it's not about just personalization or standardization. It's about striking the balance and looking at people as people, races as races, regions as regions, and genders as genders, and just slowly developing medicine which is more and more block based so that we still have the scale, but slowly moving towards personalization because otherwise, industrial growth and the scale will never be achieved. We can't switch from one to another. But on that note, because we were discussing investments, Ajay, so healthcare innovation, as we know, is attracting unprecedented and phenomenal investment corpus today. And from AI to diagnostics, and as I mentioned, from fascinating technology in stem cells and personalized medicine and precision medicine, we are seeing investments across the board. And yet, not every innovation actually lowers cost of care. Some improve outcomes as well. So, from an investor's perspective, which innovations have the greatest potential to reduce cost of care, and also scale to basically address the needs of the global south, where now more than 70% of the population lie in the next 5 years. Also, do you distinguish between innovations that genuinely create value and those that simply add another cost layer, just from a perspective of P&L? If they are making good business, does it really just work that way?
So it's very interesting. We all talk about innovation, but the adoption of innovation is not easy, especially in India. So when we are backing models, we are trying to solve for affordability, accessibility, quality of care, and of course, we expect some of these models to
And
bend the cost
accuracy.
curve.
And accuracy.
Sorry.
And accuracy of care
And
delivery.
accuracy of quality of care, I mentioned, which brings in the accuracy of care as well. So, uh, but the product development on the technology front takes an unprecedented long time. It's not easy. You need essentially data for it. You need to run simulations on it, and then you need to develop solutions, and then you need to clinically validate those solutions for the IP development. And when does it get accepted? Our Indian providers are best in class in terms of adopting the best in class solutions as well. So you have to then go in for US FDA approvals for some of those. So like one of our portfolio companies has 26 US FDA approvals. And if you were to ask how much of their revenues come from India, it'll be less than 20% of their revenues come from India. So that's a big challenge. So they're doing frugal innovation. We have cost, data, talent advantage. So we are able to develop those solutions. But the IP development takes a significantly long time. Then you have to drive adoption in the healthcare space. So first you do pilots with the providers. You have to prove that it's working in a clinical work setting. And then comes the commercialization phase. And then, of course, we all know, whether it's payers, providers, or any Indian enterprise in general, we generally don't like to pay for technology, right? We are good bargainers when it comes to technology. So it keeps getting negotiated. It should not substitute people, otherwise someone gets hurt. So it has to only enable better outcomes or better clinical patient workflow. And despite all of these challenges, we see 14,000 health tech startups in the country today. Just about 12 years back, there were only 400 health tech startups. So there must be something happening right in terms of this whole digital health revolution which has happened, right? I think government is also waking up to it with the RDIF and other BIRAC schemes, etc. They now want to fund deep tech and R&D in a meaningful way. They also have fund of funds program, which essentially helps people like us also then provide that capital downstream to portfolio companies. And then there are very few specialist funds in India who essentially are from the domain, who have the network in the domain, and healthcare is a bit of a closed ecosystem. It's patient, provider, pair, and provider, pair, pharma, and patient at the fulcrum, right? So unless and until you know how to navigate this and then get the right adoption, that will help you bend the cost curve and then bring in more affordability. So that's what we've dedicated our cause to serve the underserved 50% of the bottom population. But it's hugely challenging. These are category defining companies. Their go-to-market strategies are not so well defined. So you iterate. It takes money, people to essentially solve for it. And but fortunately now we see a lot more structural enablers in place, and we see a lot more acceptance from providers, payers, and globally, of course, you see this. Startups who've born out of India at 1/10 of the funding are making a dent in the global healthcare space. So we see a big change happening and a lot of structure enablers now in place.
No, I think you're right. So the peer-pay dynamics are a challenge, or also the LTV, customer LTV is a challenge. So I think there is a lot that needs to be solved in terms of the innovation side of it also. Because even if you're succeeding well, the benefit or the outcome you get as a technology company per patient is very limited in India. And as you mentioned quite rightly, there are lots of reasons for it, but it is still a P&L fact. So do you see India as a primary market, or is it always just a secondary market? Is always a question that we face when we work with technology companies as well. But so we have now discussed a lot of uh, approaches and understandings on how different health players and stakeholders can align. So, as we close this panel, I want to throw one last question and a small one liner to all of you, right? So, how can hospitals, clinicians, insurers, diagnostic providers, and tech companies, and even investors and policymakers better align incentives to focus on one thing, better health outcomes? Right? Today, that's one thing that we don't even measure at date. We don't measure statistics like how many patients per department are getting better. No one is really targeting that particular metric. So, how do we align ourselves so that we can start serving that particular metric and aligning it to financial outcomes? Just one liner, all of you, please.
So, in my view, we can align only if we move from the point-based payment to a outcome-based payment. So it is not volume-based payment; it should be outcome-based payment. So that's how I think we can align ourselves.
So I think we have to flip the incentives. This will have profound implications. And as Dr. Rodas rightly pointed out, we have to link the incentives to clinical outcomes and not to financial outcomes.
Yeah, the answer is value-based healthcare, and what they both talked about. If you incentivize all the stakeholders with the one common goal is about the link it with the outcome, whether it's a payment and and how you look at the clinical outcomes or something. Everything you land with the patient care and the clinical outcome, I think everything will be sorted out.
I would have a different view on this. If you link it to clinical outcomes, then the control of what kind of patients land up into your kitty is not with the clinicians. So that will push our healthcare system into a very defensive mode, wherein even the best of us would not want to. The answer to this is transparency. Now that it's very fragmented. for transplants in India not to expect us to put our outcomes 30-day, 90-day, 6 month, 1 year. Similarly, for all procedures, if our websites are expected to put our outcomes, maybe that will bring, I think that would be the first step.
At a very basic doctor level, I think the patient also needs to be responsible. I genuinely feel at a very minor level, if each individual, everybody sitting here, or as a patient can start taking care of themselves, the clinical outcomes do get better. So, agreed with the incentives. Never is this. I mean, the clinical outcomes is something we all work on, but I somehow feel if the patient also is responsible for their own health, it will make a difference.
Uh, so if you want to bend the cost curve, I think diagnose early, cure early. Uh, and I think it saves a lot for the patient, lot for the payers, and for the ecosystem at large. Not easy, but of course, with all the points that fellow panelists mentioned on health awareness and how to take care of their own health, and of course, measuring the metrics on patient readmission rates, on patient satisfaction, etc. If you're tracking all of those outcome-based metrics, at least we get in the right direction. Yeah.
No, I think
Can I add things? See, why I said that's a value-based healthcare, that's the answer would be, is like because as of now, if you see, everyone's goals are very different. Everyone are being seen differently, right? For me, as a provider or a healthcare brand, people see that, what is his occupancy, how many patients he discharges. So that's what my image impression goes about it, right? For doctors, when we hire a doctors, how many patient he's seeing it. We don't talk about that, what quality of patient he's seeing it. Uh, Insurance company has a different goal and thought process, how to reduce the claim, right? The diagnostics would be number of tests what you do it, right? For a investors, like, that's what is that your the growth, how what is going to be your EBITDA or something, right? So out of all those things, one thing we all missing is about the patient, जो कि center है. Everything is about this patient, right? And what patients want, उसको तो एक अच्छा health care चाहिए, उसको एक अच्छी clinical outcome चाहिए with the affordable cost. So since all of the stakeholders, जब तक common goal align नहीं होंगे, तब तक we won't able to achieve anything. And that's what I said, it when you incentivize that this goal with as in a common cause is about the patient care, and that's what comes the outcome, another thing.
So I 100% agree. Uh, it's easier said than done. We have been saying link remuneration to clinical outcomes is easier said than done, very difficult. But at PB Healthcare, we are trying this. And if we can pull it off, which I'm 100% confident that we will, it will be a game changer.
let's talk on that. And what Dr. Pai mentioned also is actually a very, very relevant point that which we have to keep in mind, that we are not in control with who ends up in front of us in a clinical OPD. And if we target only outcomes and not have due diligence around it and structure it very carefully, someday we might face a problem which we do not envision today, and which might be much bigger than what we are facing today as well. And it's genuinely relevant. But as we close, and I am asked to close very soon, we had a very engaging discussion. Thank you so much, all of you. But I would want you guys to want to leave one thing as we want to leave with one thing as we leave. I've always wondered what's the goal of healthcare system at large for all of us, right? Insurers, technologies, providers, the works. I think the goal of the healthcare system at large is to disappear. We should be focused on making people in general so healthy that we are not needed anymore. I mean, just as a I know it's a radical thought. It's not going to happen. We all need jobs and we all will have them in our lifetimes at least. But I think that is that's the North Star. That's what we need to target. नहीं नहीं लॉयर के पास जेल जा सकते Thank you so much, everyone.
Thank you.